and welcome to this month's UKOA meeting. I'll just see if I can go on a slideshow, which I'm sure would be better. There we go. Hopefully everyone can see my slides, and I'm sure someone will shout at me if that's not the case. So just to remind everybody that we're recording the meeting, partly to capture feedbacks and also to put the recording on the UKOA website for people that can't attend. And again, the usual housekeeping rules: if people can keep muted unless they're speaking, you can raise your hand electronically to ask questions or just pop things in the chat. We've got quite a lot to get through, but we do have a session for questions and discussion at the end. And it's really helpful if you can just to be active in the chat and provide thoughts, ideas, etc. And if somebody puts something really useful in, we might sort of come to you and ask you to speak about it. I'm going to start by just updating you on where the eye care recovery programme has got to at this point in time. So this is our sort of brand new kind of governance slide of our sort of new governance framework. It's really just trying to be more honed about telling people what we're doing, but the essential aims are unchanged, that we want to deliver rapid, high impact improvements and get on setting the basis for a sustainable future for eye care across England. We want to increase productivity and we want to increase safety, and key to that is digital transformation and technology. And really we can bring the sort of key priority themes down really into high volume surgery, integrated high flow care pathways and digital eye care transformation. And as part of this, we have not only a recovery work stream, but also a transformational work stream, which is particularly interested in the digital and technological, moving beyond the EERS into wider integrated digital ways of working. In terms of the work streams, again, try to sort of rationalise and keep it as simple as possible. So we have a recovery work stream, which is really on trying to get things done in the here and now, absolutely trying to reduce avoidable blindness and through delays and also delayed surgery, through working more efficiently and integrating pathways. And through that, giving a comprehensive support offer to regions, systems and trusts to try and provide support to help people do what they need to do, and working very closely with getting it right first time in their high volume, low complexity programme, which is what the rest of the meeting today will concentrate on. And then we have the transformative work stream, which is then looking at this more digitally enabled ways of working, and as well as the EERS, getting that done, trying to show that that actually delivers change, also looking at other more innovative digital models such as digital hubs. And then we have a number of enabler work streams, essentially around data and information, commissioning and finance and workforce. People often find it quite helpful to work out where these sorts of programmes sit with the many other programmes that are kicking around NHS England and NHS Improvement, also trying to improve services both in eyes and others. And again, these slides will go up on the UKOA website afterwards, so you can have a look in more detail. We now, it's probably worth saying specifically, we now have the National Eye Care Board up and running, so that's in which the national programme leads plus the regional leads, optometry, ophthalmology and programme leads for all 7 regions meet to talk about the eye care programme, and the colleges are invited as well. And we're also looking to re-establish the eye care reference group, which had been a bit, I suppose, slightly sort of either downgraded or not so actively involved, and we really want to re-establish that so that we're working a bit more in partnership with key stakeholders rather than potentially going off at any tangent without working closely with the right people. So what have we actually been up to? So we've been spending quite a lot of time trying to provide hands-on support to trusts, to systems and regions. We have regular meetings with the regions and the systems, and we now have 3 operational leads. So these are experienced service managers of ophthalmology. So as well as bringing that kind of expertise, they're also acting as the relationship managers. So they split up the regions between them to try and give that direct point of contact. And how are we delivering the support? Well, there's all the material on the Eye Care Hub, also through local workshops, advice, our external objective presence to help facilitate, signposting to all the materials and guidance that there are out there, and putting people in touch with each other. So peer support is incredibly helpful, and you know, if you're looking to do something and someone has done it before, it's really helpful to be able to talk to them. We're also crafting and putting up on the Eye Care Hub lots and lots of case studies about different aspects of the programme. So I'd encourage people to have a look at the case studies section. It's really helpful, and it's got contact details for the people who are involved in those case studies, and they're happy to be contacted to talk about what they've done. And you've got the link there for the Eye Care Hub. And again, I constantly say this, but I'll say it again, please get on there, because people ask me constantly for materials and guidance, and they're all on the Eye Care Hub, the sort of things people are asking for. In terms of metrics and data, as well as the stuff that's already on the model hospital for ophthalmology, and there's an ophthalmology section, and if anyone wants to know more, please get in contact. We've also been working with Getting It Right First Time to get a sort of a small subset of absolutely key data on eye care that we simply can't get from anywhere else, and are doing a national collection, which we're hoping to try and do quarterly. It's a fairly small set of questions. If that hasn't been sent out already, it should be sent out imminently, and we'll get that up on Model Hospital as well. So you can start to see some of the things that really interest you, like how many diagnostics only appointments are people doing, how much is coming through primary care optometry before it gets into hospital. Another really good bit of work is being done by the workforce team, who are about to launch a new guidance document with a competency matrix, just showing people exactly how they can use both core competencies with a bit of local training, or map both things like the OPT or OCCF and the higher quals and MSCs and all sorts of other things directly to pathways, so you can start using your workforce better without, I guess, having to argue endlessly about who is allowed to do what. So that should hopefully help. And the workforce stream's really getting up and running now, and doing lots of modelling, hands-on support, and that's doing really well. The commissioning workstream has also started to get into gear now, so there are now commissioning advisory groups and various workshops. If anyone's interested in being involved in any of those, again, just get in touch and we can put you in touch. Our patient information videos, which again all map to both the pathways, the cataract, the glaucoma, etc., and also to things like what can I expect from a diagnostics only virtual appointment, what can I expect from remote, what can I expect when I go to enhanced services and optometrists, are all pretty nearly finished. So I'm hoping we'll be able to start releasing some of these imminently, and then they'll be free to use for everybody. We also have to contend with, and this is the pain sometimes of working in an NHS England programme, there's a huge number of urgent requests from very high-powered people to do things at short notice, to tell them what we're doing, to try and tell them exactly how many more cataracts we're doing this year and exactly how many virtual clinics we'll be doing, all of which is somewhat difficult to predict, shall we say, given what's actually happening on the ground. And then you can see some of the webinars and workshops that are coming up, and if anyone wants more details, we send out the invitations always through the UKOA, but if anyone's particularly interested or wants to know the exact date, just do get in touch. One of the things that's sort of fairly hot off the press, and some of you will probably have received some of the documentation, is looking at the cataract follow-ups. And you'll remember that the two colleges put out something that essentially said, I'll paraphrase, but in these time of crisis where we can't even see glaucoma who could be going blind, why are we doing post-op cataracts? Why are we doing them in the hospital? Definitely, but perhaps there's an argument of, do we need them at all, and is it okay to just do a site test and send the data back? So a successful case has been made for some money to fund exactly that, not a fee exactly, but a contribution of £5. So there's people are reasonably low risk, they can be completely discharged, and the optometrist then asked to return the best corrected visual acuity and the refractive error back to the hospital. And lots of guidance has gone out on guidance pack on how to do this and how to implement this. The single most important thing is to not have people that don't need to be in hospital. This doesn't mean that everyone has to immediately chuck away the enhanced assessment post-operatively, but obviously some places are looking to see whether they might want to move from enhanced post-operative assessments by optometrists to the sight test model for some patients. Another thing, and again, I've sent this around to UKOA colleagues, was around the second half of the year sort of planning guidance and essentially pots of money that are available both in terms of services, the targeted investment fund, the services that contribute to recovery and reducing waiting lists, but also there's a specific tech fund as well, looking for sort of digital solutions which will help this. The submissions, I believe, have to go through systems and then regions, but there are providers that have looked to do that through the system and region route. And at the moment, the decisions on this, I think, are still being honed. So I think there is potentially still opportunity at the moment to get requests in for these. So what's happening in terms of, are we getting there and are we solving the world's eye care problems? Here's the latest figures from NHS England, so you can see that the overall waiting list is still climbing at the moment, probably as more patients who didn't come forward during surgeries are now coming out of the woodwork to add to the backlogs. This is the 52-week plus waiting list, so people are concentrating on trying to get down the waiting list for the people who've waited longest. So you can see that overall it has come down as people have done that, but it's starting to plateau. If you then break it down by regions, you'll see that for some of the regions it's actually starting to creep up again a little bit. So it's definitely not this big backlog is absolutely not a solved problem at the moment. So what have we learnt? Why, I'm going to again very honest with you here, why have we not, with all our marvellous planning guidance and all these opportunities and ideas for making change in eye care, why has it not all happened, and why have we not seen bigger movement in terms of the backlogs and the waiting lists? I think that, I mean, this is, I suppose, perhaps what I've learned, perhaps rather than what we've learned. I think it's very interesting as you start to sort of get inside NHS England and see upwards into the leaders and the politicians and all the sort of top people. I think there's this sort of expectation that a lot of what we want to happen is just efficiency. So why can you not just do it? You're all rubbish. Just make the change and do more cataracts. And I think that shows really there's a bit of a disconnect sometimes between very senior people and people at the coalface of clinical. And we all know that there are numerous barriers which stop us making even the smallest changes in healthcare provision. And a lot of these barriers have not been swept away, and therefore we can't do what we'd like to do. In addition, change is actually, it's painful, it's slow, and I think we probably need change in how a lot of the improvement stuff is run as much as we need change on the ground, that there are a lot of different programmes and a greater degree of coordination would probably help, I think. There's lots of politics, and also there's no dedicated money specifically labelled an eye care pot for you to do your eye care things, so that makes life difficult. And there's been a lot of focus on the surgical waiting lists, which is great in the sense that eyes is a big part of that, and so eyes gets attention, but it is distracting from the blinding retinal and glaucoma problems in outpatients, which really need to be solved, and is what gets to a lot of our hearts. And I think that, again, clinical leaders are struggling to really be heard and empowered to actually make the changes in the way that they know work. Here's a list that we developed to try and answer some of the questions we're being asked about. Why have you people not just solved your efficiency problems in theatre? And we did some of this work with the college, and some of you may have been involved with the clinical leads survey that was done through the college. What are all the reasons why you are not able to do 8 or 10 on a list? And here are just some of these things which make it extremely difficult. I won't read through them, but I think you get the idea. So how are we going to get over this? Well, I think one thing that's interesting is that clinical leadership is being brought in at the very top of NHS England in improvements. Some of you may have either heard or seen of these colleagues, Tim Ferris and Anne Kinderler, I think is how you pronounce it. So they're starting to be brought in to sort of give more clinically informed advice at the very top of the tree. I think some of this eye care feedback that was organised through the college, plus the interactions that are happening across the country about why have you not done this, these barriers are just starting to be understood, and what might need to happen to really drive change is starting to be understood, but it's an early conversation, and we are seeing that NHS England Improvement are starting to move towards a greater coordination of the improvement programmes, although again it's a work in progress. I think another thing that's starting to be understood is the fact that we don't have the right business intelligence. In other words, we do not have the right data to do what we want to do. And EYES has been asked to create a wish list of data, and we're hoping that that might lead to perhaps some of this data that we lack being collected more routinely. So there's a lot of concentration at the moment on, well, OK, you know, there may not be money or may not be money with an eye label. So what can you do in year with little or no cost? And people are pursuing that. And we've been trying to craft what some of the key big changes might be within EYES, and trying to make perhaps an argument for where we can have more targeted funding or a little bit more push in terms of this really needs to be done. And as part of that, some of you may have been involved in, we're asking regions to feed back to us on where they are versus all the planning guidance actions for EYES, to show that people are just not able to do this. So it's not a sort of performance management thing, it's more this is harder than perhaps we might have all realised. The sort of interventions we've been looking at are essentially around, you know, some sort of rationalisation of cataract surgery. Do we need to concentrate on smaller numbers of cold sites with ring-fenced space and ring-fenced workforce to deliver cataracts? And can we now get a more level playing field with the independent sector, who are doing far more work than they used to for NHS patients, particularly cataracts? And a conversation has started with all the big providers of eye care in the IS, and at the moment they're definitely making all the right noises that they do want to do things differently, let's hope. In terms of outpatients, again, asking for a really specific set of data that would really help us to identify and manage what we're doing. Ophthalmology, digital and diagnostics space and workforce. Could we use money released from biosimilar drugs, from anti-VEGFs, to be reinvest? And what can we do in terms of primary care? And there's some work going on to look at what's the full primary care offer, and trying to find some systems that would volunteer, possibly with some funding, to deliver all of this and to really get the evidence about what should the cost and what be for that, what's the evidence that it really works. So that's a canter through. Again, can't emphasise enough, get on the Eye Care Hub, it's all there, there's loads of juicy material there. So I'm going to stop presenting now, and I'm just going to hopefully seamlessly hand over to Graham and Eleanor from Getting It Right First Time, who are going to talk in a little bit more detail about what's been going on with the HVLC programme. Thank you very much for coming.
Thanks, Mel. I'm hoping this is seamless from what you can see. So afternoon, everyone. I'm Graham Lomax. I'm the Implementation Director for GIRFT, and joined here by Eleanor, who is our National Programme Director for the HVLC Programme. We also have Josh Wall with us, who's a clinical fellow with GIRFT, who will talk a little bit about some work with their colleagues from Lancashire shortly. So just going to talk a little bit about where we are as an HVLC programme. Some of the kind of thorny challenges that Mel's alluded to, and then a little bit about our next steps. Let's start with a bit of positivity, though, from an ophthalmology perspective. So just in terms of the specialties in scope within high volume, low complexity, you can see there on the left how they're all faring in terms of activity against the BAU, so against the activity pre-COVID, and you can see the light blue line, ophthalmology, at the top there being the specialty that's got closest to that level, and on the right, so that this includes the independent sector, and clearly you can see on the right a lot of that has been driven by increased activity in the private sector. Obviously that still leaves us with a significant challenge, So this is just the range of specialties from a waiting list perspective, and ophthalmology being the second largest there, which will come as no surprise to anyone, given just the volume of the specialties, the clinical prioritisation, and to an extent, and probably a subjective comment, but I think a specialty that has been perhaps neglected in some areas in the past. So as Mel said, I think that's an opportunity at least for us to get some focus and attention, so I'm just going to whiz through a little bit of the HVLC programme, and as I say, I'll talk about the eye care or ophthalmology specific elements of this as we go. So there's 4 objectives to HVLC. So the first, very much the core of GIRFT, isn't it, is reducing unwarranted variation to improve outcomes for patients. And one of the aspects that we've been really keen to develop is this clinically led improvement infrastructure, bringing together system, regional and national, and of course there's some real positive developments there, with a lot of regional leads being appointed, and I think there's some work to do. Clearly, it's been a large programme. Not clearly Cataract is just one bit of it, but there's some opportunity there, I think, for us to really bring that network together and make sure that we provide a support offer that's practical and real and speaks to some of the, let's say, the kind of clinical and operational realities on the ground. Just in terms of data, so we are for across the other surgical specialties, we've got really good data on model hospital already. It's a little bit different in ophthalmology because the HES data is a little bit less valuable, or a little bit less useful, I think, which is why we've taken the questionnaire approach that Mel's alluded to. So that went out toward the end of last week, so hopefully some of you have seen that, and once we get that back, that will give us an opportunity. We'll get that on model hospital, allow for that benchmarking at trust and system level, and kind of ongoing monitoring of that position going forward on a quarterly basis. I just want to mention that we've got linked to the programme. So Tim Briggs is visiting pretty much every ICS in the country. So we're going to get some miles done, I think, over the next 3 months. And this is to sit down with the executive and the clinical leadership with at the system level to go through some of these, some of the issues we're facing, some of the challenges, what support we can offer, and again, get down to some of the real levels of detail. So I think where there are a challenge in the system, that there are some blockages, I think some of these visits will help progress that, and we have seen that. We've done a number of these already, and in fact the Lancashire project that you'll be hearing about shortly stemmed from one of those visits. So we've got the standardised best practice pathways, which you'll be aware of. In terms of the capital investment, so I'll probably pause on that. Ellen is going to pick up the issue of hubs later on, and of course, as many of you have seen in the press, there is of course funding associated with that. So again, some reasons to be positive, I think, going forward. So one of the other objectives is about access, so reducing the variation in access and reducing the variation in the waiting times. We were in one system a couple of weeks ago, and between 2 of the trusts, one was had a waiting time of about 4 weeks for the same procedure, and the other trust it was over a year, and that is just not right. That said, I think we also recognise that that's not mutual aid or transferring patients between trusts is a lot easier said than done, particularly in some of the geographically challenged or where you've got difficulties with transport and what have you. But actually, there are some things that we need to do, kind of at a system, regional, national level, to make some of that easier, whether that's at a referral source or later on in the pathway. But some of those things just around kind of HR and IT is how do we break through some of that to get the sweet spot. You know, not all patients are going to be travelling large distances, clearly, but in some systems we absolutely do need to have a better way of using our capacity more flexibly. Just to mention the demand and capacity modelling, so this is something we've been piloting with a number of systems, and I think we are pretty much there now with a product, and would be keen to do this with as many systems nationally as we can. But it really just shows, so when we've done that, it shows looking at the backlog, looking at the level of activity we've got going through. Again, this is at system level and trust level, is so what would be in the art of the possible if we were able to fully optimise pathways and then what is the residual challenge we've got to enable those more strategic conversations, whether that's the IS or a new facility or whatever that might be. I'll come on to the optimising pathways in a second. In fact, let's do that now. So in terms of so the third objective is to reduce the waiting list by improving the productivity. So clearly, again, the GIRFT principles would be, if we get it right from a clinical perspective, that enables some efficiencies to be delivered, which will obviously contribute to the waiting list. And as Mel alluded to earlier, that isn't just, oh great, here's a pathway, do 10 cataracts. It's life's more complex than that. I think the other thing to emphasise, I think, based on some perceptions almost, that it's almost binary, that you've got a list that does 10 cataracts on in a protected hub or not, and that's not. But actually, HVLC is frankly about improving from a baseline, and in some cases that might be units being able to identify process improvements or relatively modest investments or what have you, that will enable you to go from 4 cataracts to 6 cataracts or whatever it might be. It is about improving from a baseline within a set of constraints. And again, looking at the pathways and if helpful, the capacity demand work we've done, changing the conversation to, so what would it take? What do we need to get to this level of whatever it may be, as I say, 10 cataracts eventually? And some of those things will be the art of the possible, as I say, about process improvements. It might be about scheduling, it might be about administration, it might be around some equipment issues, and some of those things, therefore, we can take forward. Of course, there may be other issues that we can't tackle straight away, and I think we have to recognise that. And again, core GIRFT principles is that this is about clinical insight and clinical conversation wrapped around the data. We can't just have a one-size-fits-all approach. So again, that kind of system, regional, national, clinical lead structure, I think we need to use to make sure we make the best of those conversations and have supportive conversations. The intensive activity drives, I think, certainly have a role in all of this. In fact, I don't know if anyone's from Barking's on the call, but I did see by the powers of Twitter this weekend. I think they've had a drive over last week and treated 1,000 patients, which is an incredible feat. But I think learning from those, it's not about the initiative, it's not about the patient you deliver in that week. It's about what that can build into the pathway. It's the improvements that you identify. And actually, sticking with Barking, but I know in their orthopaedic work, which is a little bit further down the line, I think, where they're in about the third iteration. So through the first drives, they made tactical investments in things like the admin and the scheduling. But the learning they took from that, they're now embedding into the pathway going forward. So it's becoming BAU. It's not just one-off drives. And the positivity and the impact on the morale and the teamwork of having all the multidisciplinary team involved in that improvement, I think is really paid off. So I think at this point, Eleanor, shall I pass to you?
Yeah, thanks, Graham. Hello, everyone. I'm Eleanor Bechberger. I have been with the GIRFT HVLC programme for the last nearly 4 months now, so I'm just finishing off that whistle-stop tour of what we're focusing on at the moment. I just wanted to say a few more words specifically on our attempts to accelerate the setting up of elective hubs, which has been one of the key features of the programme so far. As you know, we believe that they can make a really positive difference based on several case studies on which we've also talked about quite widely. We've seen that they can make a difference where individual hospital trusts manage to carve out distinct areas within their hospital setting of splitting out as much as possible hot and cold activity. Obviously, the kind of famous case study we've been showcasing on the country, for example, Croydon, who is still operating at 120% or so of pre-COVID activity levels, purely based on some relatively simple and actually affordable changes to just the layout within the hospital. But the other key initiative, obviously, we've been promoting was to coming out of the first wave, particularly across London, was to set up system-wide elective hub sites that would take patients from a number of organisations and then treat those at dedicated sites where the conditions for doing things at high volume and high productivity levels were possible. So where are we actually on this? The answer is we don't know enough about this yet. So we've just gone out to all of the regions in the country to actually find out to what extent these hub models have been progressed and implemented, and have asked everyone to let us know how many elective hub sites there are. And across what specialties they're operating. So very hot off the press, the initial returns we just had, you see in the table summarized to the left here. So regions have reported, and we still need to validate this information, that currently we have around 38 elective hub sites which focus on ophthalmology services. You see there's really big disparity between regions here. So the big majority of those sites are located across the Midlands and also London, with very few in the other regions. So in itself, an interesting finding. We're still validating this, as I said, with colleagues now over the coming week or so. And then the next step is that we are contacting each of those hub sites. We're going to do a standardized collation of some basic information and data about how they are operating, what the added value and impact has been on their ability to recover services, and generally on how productive those services are, what the impact has been on staff and on patients, just so that we are expanding our evidence base on what are actually these hub models that work best. Have they actually delivered the intended impacts that we thought they would? And also importantly, what did it take to set them up? So therefore, what is required to accelerate setting up more hub sites if what we find would strengthen our belief that this is indeed the right way forward. But so I think this is really at the moment we've just have not had that sort of detailed knowledge that is really important to have a really firm strategy going forward. So obviously, yeah, very happy to come back in due course once we've completed that work and share the results, and also very happy once we validate that data to sort of share with everyone a bit more detail around where exactly those hub sites are in each region. And obviously also, as we said, we're trying to tease out what different models they are. The other thing is also, and I think Graham's alluded to this, we have realized that obviously, you know, we need to provide much more direct support and the levers for people to actually push forward with some of the recommendations we have made. On elective hubs, obviously, there is quite considerable capital investment required in some instances to progress with that model. So the good news is there is obviously a lot more capital flowing at the moment. There have been over 700 bids for the latest in-year capital fund. That is just these are just being reviewed, and we had managed to make sure that, you know, investment, particularly in elective hubs or anything that would really help to improve the flow of patients also within existing settings, was quite at the forefront of what some of those bids could be for. So colleagues are just reviewing this, and we're trying to work really closely with them to make sure that, you know, we also have a say in terms of what we think are really useful areas to have a bit more targeted investment. And obviously, it's been in the sort of health papers today that it looks like there's further billions of more, also hopefully longer term capital funding coming, which might allow us to have a bit more of a forward-looking investment strategy, not just for in-year, but also for some slightly larger projects, which take slightly longer to implement, to achieve that strategy around having some more firmly protected areas that would allow us to have much more resilient services going forward. So hopefully a bit of good news going forward, and that's kind of a key emphasis for us at the moment. And yeah, I think that was our whistle-stop tour, Mel, so handing back to you.
Brilliant, thank you. Actually, if you could just unshare the slides for a minute. So we've got a few moments before Josh's talk for questions if anyone wants to put their hand up. I think that that's a massive amount of information actually you just shared, and I think for me what comes across is that kind of, not from you so much, but again from the powers that be, if you like, the people are starting to hear that what's stopping us, and all those boxes you had about the enablers, we need this, we need that, we need the other, I think is really great. That's a direct response. What people are telling us is stopping them doing it. And that's great. I think the recognition of that and the will to try and sort some of those is, I think, a really big mindset change, which I think is much more likely to get us there. So I think thanks for acknowledging that. I was going to ask you again, unless someone shoots their hands up, some of the things you mentioned around things like sort of patient choice, for instance. So I know lots of people have said, oh, it's absolutely great, yeah, we found some capacity down the road and we have to ring up all the patients, and all the patients go, I'm not going. Is there any sort of, I mean, I see you've acknowledged that, is there any specific plan going on behind the scenes to look at how we might do that?
Yeah, do you want me to start? I mean, it's interesting, Mel. So I think there is there are places that have managed this better than others, and I think we have to try and bottle some of that and really understand who has the conversation with the patients, how's it had and when, etc., and characteristics that make that conversation go better. And as you know, there was the example in London of I think 1,000 patients transferring to a different system, and I think only 1 out of that 1,000 didn't want to travel. Partly that was because transport was provided, of course, which again makes a big difference, and we've got to factor that in. There's a financial impact, and that isn't going to suit everyone, but there are ways and means, and again there's a sweet spot. So you often hear things like patients won't travel. We've got loads of examples. If Tim was here, he'd be talking about United Links, and patients travel 40 miles and are very happy to do so because the services improve so much, and the clinicians are happy to do so. But again, there is a I don't know quite what that distance is, that's the sweet spot of distance, but there will be a limit. So I think what we're trying to do, so a long answer to the question, what I think we've recognised is we want to work with operational colleagues to develop some guidance about some of the factors that make it work, in terms of the conversations with patients and some of that nuts and bolts of how we do it. So we've engaged with a few groups. We've engaged with Proud to be Ops, who some people may know, who have got kind of a group of operational managers, and again talking to systems where they've done it and seem to have had better success. So yes, it's we've kind of added it to our to-do list to do over the next few weeks. And certainly if there's any colleagues who've got any pearls of wisdom or have been involved in that in the past who would like to contribute, then I'd be delighted to hear from you.
So this, Graham, from what you're saying, it sounds a bit more like it's more about sharing good practice of where they've been able to do this than some kind of blanket statement released from on high saying we have now suspended patient choice, you'll go where you have to. Is that about right? I
think so. I mean, again, there could be conversations I'm not aware of on that one, but yeah, certainly I won't be that won't be coming from me, that one.
That's fine. And there were a couple of things that you mentioned that you're specifically interested in, and I know people have asked us about in terms of the eye programme support. So you mentioned the kind of digital pre-op and post-op assessment. Is there going to be, what's happening in that? Is there going to, because I know some people I think might be applying for things like that through the sort of tech funds and things. Is there going to be a system coming out, or what's happening with that?
Do you want to take that one?
Yeah, just to update you, Mel, so there has been just a recent application round that was coordinated by NHSX, specifically for investment in those areas, and we've been able to confirm so far funding for 5 systems. However, the quality of bids was extremely high, so we had 26 applications all around, although originally there were even more. It only transpired quite late on in the process that accelerator schemes weren't eligible to apply. So in total, I think there were another 10 or so which had to be excluded. So really the huge majority of systems had provided bids, and many more than the 5s were what you would regard as sort of above the line and definitely investment worthy projects. So we are proactively just talking to colleagues in NHSX because again, most colleagues might know there's another actually quite substantive digital investment fund, which is theoretically also targeting sort of very similar areas. So we've been trying to make the point that obviously, you shouldn't have systems go through another process of having to come up, fill in a different template and put in another bid if, we have actually high quality bids here. And the blanket funding and support for digital consent and digital pre-op, we would consider as, an absolute worthwhile investment in any system out there in the country. And obviously there are certain technological solutions that have proven to be really successful. So why wouldn't we kind of have a more focused investment strategy around those? So, but unfortunately, sort of early days. So we're trying to influence, we're trying to talk to colleagues and work with them, but and see whether we can. I know they're practically looking at funding some more of those bids, but there will definitely be more funding and opportunities there in that area.
Thanks very much. So what we might do now, I'm not so sure I've ever seen the UKOA so quiet. Normally people have got all their hands up and they're obviously listening in, so that's fine. So we'll move on to the next presentation, but please do, as I say, stick your hands up or somebody other than Sudeshna could she's write something in the chat, because otherwise she knows I'll then pick on her to speak, poor thing. So I'm really pleased to welcome Josh. So Josh is Getting It Right First Time clinical fellow, and he's been doing some work I think arising from a visit from Tim Briggs. So Josh, over to you and tell us more.
Thanks for that introduction, Mel. And we've got Bertie on the call, who is the clinical lead for ophthalmology at Burnley, so he'll be chipping in as we go through these slides. You're absolutely right. So we visited Burnley, or GIRFT visited Burnley at the beginning of August. Burnley is an elective, slides aren't advancing. Oh, perfect. It's an elective cold site that belongs to the East Lancashire Hospital Trust. We got to see firsthand some of the challenges that they were experiencing running theatre lists as efficiently as possible, especially while being compliant with national COVID-19 IPC guidance. We talked in detail about implementing HVLC pathways and some of the other initiatives that other trusts were doing to make the best of the limited resources that they had, such as hit lists that they were doing at ENT over at Guy's, and also some trusts who had done elective drives that we've already kind of heard about this morning. Knowing how successful these elective drives have been in other organisations, we thought, you know what, it could be a success at Burnley too. So that's how we decided to take it forward. And there's been a huge precedent of how successful they've been. Obviously, on the left of your screen is a news excerpt from the BBC covering the drive that happened at Moorfields, where they did over 700 patients in 6 days after the first wave of the pandemic in September last year. And as Graham said, at BHRUT, they've been doing elective drives in orthopedics, ophthalmology, ENT, and they've been a fantastic success. And it just shows that these kinds of initiatives are perfect for kind of any type of trust, whether or not it's a tertiary centre or a DGH type hospital. So in terms of our project, it was always set out to be an elective drive, a special event for a defined duration of time, where all the energy in the department was focused towards one goal, which was performing, or which our aim would be to perform high volume, high quality cataract surgery with a low complication rate. And of course, we're doing all of this to tackle the backlog that we're seeing up and down the country. And we really see this initiative as our chance to inspire and motivate staff, a lot of staff nurses who were redeployed to intensive care in other parts of the hospital during the pandemic, and really demonstrate to them what can be done and create that attitude that change and recovery really is possible. And as Graham said, we want this week to really be a springboard to working towards high flow cataract lists and more efficient working in the future. And hopefully, if we can make it a goer in ophthalmology, then we can see super weeks be introduced in other specialties such as orthopedics. So the first thing we did was look at the cataract pathway at Burnley from beginning to end. Speaking to theatre managers, ophthalmology managers, pre-op assessment nurses, understanding exactly what literature gets sent out to patients at what time point. And it quickly became apparent that for this elective cataract drive to really be a success, we'd have to significantly increase the flow of patients through theatres, and that really we'd have to put this elective drive on hold until we implemented some of these significant changes to get the flow up to an optimum level to then run the cataract week. I think we're so lucky in ophthalmology to have so much guidance in terms of how we can transform systems. But you read all these documents, it makes perfect sense, but obviously making it a reality is sometimes a little bit more challenging. I'm going to pass over to Bertie, who's just going to talk a little bit more on the specifics in terms of the good things that we're doing and things that we're working on to make high flow lists a reality, and things that we're trying to get all set up prior to embarking on our Cataract Super Week. Bertie?
Thank you, Josh. So the next few slides are quite colorful, not because I like the colors, it's because it's easy to understand which is good, the amber is not so good, and the red is not very good. I've just put my slides on a patient pathway when they come in from the point of referral till the time of discharge. So we know exactly where we stand, our good practices, our bad practices, which are the ones we need to change for the high volume week. And Josh and Graham, the point that I insisted and the reason why I'd agreed this department would do this high volume work is to kind of inspire a change, the attitude that should help us move on to the next stage. So the optician referrals, we have been with the integrated eye service for I think 7 or 8 years. We've worked a lot with our local opticians. I should say we are very lucky to have a CCG who've been quite open. They do. We have an open conversation with each other. So we have worked quite well, and it's almost an 80% conversion rate from the cataract referral to the surgery. The cataract clinic is something that we really need to increase our standard on in terms of consent and risk stratification. We do have a case sheet, which is all quite obvious. But for various reasons, we have lost a significant number of our experienced ophthalmic trained staff. So biometry, which is a crucial part of this assessment, is not happening during the cataract assessment. It happens in another day. And Josh knows about our local assessment, which is probably it probably takes 45 minutes just to read through the document for a 10-minute surgery. So it is painful for the nurses to do it. It is painful for the patients to answer it. And that just stops everything from going on to a really high flow list. Now, what happened before? 8 years ago, we used to do 8 cases on the list. No list was considered as high volume. Everyone had to do 8. All the complex patients were distributed equally among the surgeons. We had a stratification that we followed, no more than 3 complicated cases a list, and we would keep the complicated cases as well as routine cases on a balance. And all surgeons had to, do the complicated work. Now we struggle to do 6 cases. There are pre-op issues, admin issues, the physical space. We have only 5 chairs to bring in per patient. COVID swab is another issue, and we have a very, what should I say, infant ward staff who are just learning about ophthalmology. And people have got used to the comfort break after every case. It's easy. 10-minute surgery, let's have a break. 10-minute surgery, let's have a break. And COVID has just forced that break on, and people have become really comfortable with that break. Some of the problems this is specific for the unit here at Burnley. The notes have always been a disaster, so that continues to be one. The pre-op ward rounds, we are changing that from non-surgical doctors to have surgical doctors. The slit lamp assessment, do we need a slit lamp assessment right now? Because the patients have been waiting for almost 3 to 9 months. It is crucial to have that slit lamp assessment. Hopefully in the high volume work that time gap is less and less, so we probably don't need to do the slit lamp assessment. The pre-op ward staff, we have a very young cohort of staff now, but they have no ophthalmic knowledge. They're just out of nursing school. So it will take time to train them. It's not going to be a quick fix, but we are on it. Biometry practice, again, this is something that I would recommend. Having band 3s doing biometry is dangerous. We have accepted it. We have to modify our pathway. As something that we are looking at pretty closely. Now, again, in terms of theatre, as soon as they see 6 cases, I think 90% of the people know, even if they delay the start, they're going to easily finish on time, because it's not long cases. Even if 1 or 2 become complicated, you can easily finish ahead of time. There's quite a lot of lethargy. 8:30 list doesn't start until 9:15, and then it just drags on. And some people have really asked me the question, why do 8 when you can do 5? Can never answer that. I just could not answer that. What are the good things, right? The surgery is not taking any longer for us. We have, in terms of kit, no one can complain. Excellent microscope, excellent phaco machines. In terms of consumables, we have some of the best. It's the lethargy between the patients. It's the bureaucracy, which is kind of it has been coming in even before COVID, and COVID has just pushed that process, and it's kind of embedded in. And surgeons also have to take a little bit of responsibility for that. They have to fight that lethargy and kind of push it through. But there you go. That's something that I'll have to pick it up with all the surgeons.
So we've got our work cut out, haven't we, Bertie?
Yeah. But
so
in terms of post-op, I think in terms of post-op, it's been quite good because we discharge all the patients back into the community. The discharge medications are there in the ward, so that's been going on quite well. So there are some good things, but there are some significant bad things that we need to alter. We are doing things differently, but we will get there.
Mel, I'm just conscious of time. I know we've maybe run over a little bit. We've got a few more slides. Do you want us to carry on, or do you want to go straight to questions?
No, it's fine.
Okay, fine.
We haven't been overwhelmed by questions. I can see Declan's got his hand up, but you finish off. Okay,
so just a few slides. So we've basically put all that Bertie has discussed into a table, and this table goes over about 3 and a bit pages, identifying each thing we need to look at. So in the first column, everything you see there has been taken directly from the GIRFT HVLC pathway. And then we've also added in things that are unique to Burnley. So for example, the workforce issues around biometry, the overwhelming amount of nursing documentation that needs to be streamlined. So everything that we have to address in order to make high flow list a reality, and in order to get our Cataract Super Week kind of off the ground. And we've been starting to write new pathways, new guidance documents. This is a draft of the pre-op assessment guideline that's going to be part and parcel of the new package of improvements that we're putting in place. And in terms of what we're doing, we've kind of come up with the mantra that practice really does make perfect. So we're undertaking a number of pilots or practice runs. Bertie undertook the first one-stop clinic a couple of weeks ago, and there's a huge amount of learning from each one of these kind of pilot events. I think we understood that there were patients coming to these one-stop clinics that were never going to be appropriate for high flow list. For example, they needed a general anaesthetic. So how do we work out these patients from the outset so we don't waste an outpatient appointment and get them to the correct pre-op assessment clinic where they're going to be assessed for a general anaesthetic rather than local anaesthetic? We were dispensing dilating eye drops for the first time, which is something we haven't done before. And with the patients that we've got from our pilot one-stop clinic, we're going to hopefully do a pilot high flow list as well, to continue kind of the learning. And I think it's paramount to practice, because we can't just start our high flow week or our super week in 6 weeks time and then expect the staff suddenly to adopt all these new processes and changes. We've been speaking a lot to trusts who have got well-established high flow lists, learning as much as we can from them, and we're in the midst of organising an educational event for the whole ophthalmology department. I think implementing change really is quite slow. I thought we would maybe have this project done by now, but obviously we've still got a long way to go. There's appetite for change, but it's difficult for people to alter ingrained practices. So for example, patients at the moment spend 3.5 to 4 hours on site, and then we're trying to get that down to obviously the GIRFT target of around 60 minutes. And that's quite a big kind of psychological change for everybody. The elective waiting list backlog isn't the only problem. There's huge workforce problems. The COVID-19 IPC guidance is a real headache. And we're finding that you have to have a contingency for everything for these high flow weeks to work. And there's lots of things to consider. So what do we do with the patients who have already been preoperatively assessed, but for example, we haven't chosen intraocular lens, or we haven't given them pre-dilating drops, and they were seen maybe 6 or 9 months ago? You know, what do we do with those patients? What do we do with the emergency eye care service during the elective drive? What about if we focus on cataract work? What about all the non-cataract work? How do we select patients who are appropriate for our elective drive? How do we manage those high-risk patients? Because if we only do the kind of easy patients, we're left with a waiting to really challenging high risk multi-comorbid patients, which is another headache. How are we going to pre-up assess the 300 patients we're hoping to get through on our elective drive, and what will the COVID rules be when we come to doing our drive in a few months' time? Who knows? So there's a lot of things for us to work through and to straighten out before we embark on this challenge. But that is just a little bit of a whistle-stop tour about what we're doing and how we're trying to work with the the HVLC program and the high flow cataract pathways, and that's it from us.
Amazing, thank you. If you mind unsharing the screen, actually,
yeah,
Josh, that we can see each other. So I mean, that's amazing and really honest, I have to say. And Bertie, I love the way you're sort of describing it, because that is it. It's this like great big long list of things that you have to overcome, and this is the level of detail and attention to detail that you have to do to get through it. Declan, you had your hand up first.
Thank you. It's to start on a negative note, it's depressing that you were actually a pretty slick unit before COVID, doing 8 cases on a list routinely with and not regarding that as anything special. So it's depressing you've had to go back to 6, and people now regard 5 or 6 as the norm. You're correct on a positive note that there is no single fix to this, and you have given us a list of things that you are working through with enormous effort to fix. I think the pilots are essential to get to overcome in-house resistance and to bring people with you. It'll also improve your relationship with your providers if you're seen to be doing this. But ultimately, in answer to your question, why do 8 or when I can do 5? The answer to that brutally is, if any CCG or if any NHS trust continues to do that for long, they won't be in business. The commissioners will just stop sending them surgery. It'll all go to the IS or the AQPs. It will just be impossible for the commissioners to justify that sort of response. Unfortunately, so this really, in many ways, the sooner you get your high volume week running, the better. But all I will say is the reason 60% of cataract surgery in the UK is now done by AQPs is partly because of some of the problems you've just described, unfortunately.
Right, thanks, Declan. Graham.
I would just say, I mean, one of the reasons I love this presentation, it's reality, isn't it? And obviously part of the point of this, kind of from a selfish national perspective and through Josh, is to try and document this learning and share it as much as we can, because again, some of these conversations, some of these issues that Bertie's described is, having similar battles and conversations and what have you up and down the country. So we'll do as much as we can to try and document it.
And Graham, will more of us be able to have a Josh?
Yeah, I was going to say that was the other bit, and I think part of this is, what should our support offer be collectively going forward, and is it cloning Josh? Is it Josh? Tim will be perfectly happy sending you to every system in the country, as you know, Josh. But no, in all seriousness, that we if this is something that we think is what we should be replicating and would help get other systems off the ground, then we need to find a way to do that.
I think it's interesting because a lot of places have said it's not just for the surgery, it's for everything. They've said that they're struggling to find, improvement support. So I think I might ask Bertie, how important has it actually been having someone from outside come in who can be perhaps got no axe to grind, can spend a bit of time? Has that been a game changer?
It's very useful to have someone like Josh because one of the problems is as a clinical lead or as a surgeon, when you say, why are we doing this? Why don't we change? Why don't we change? Because it's coming from inside the department, there's always a resistance. So when it comes from outside, Josh has just helped to kind of consolidate all the knowledge from other departments. If someone from outside comes in and say, right, hang on, someone is doing 20 cases outside. Why don't you guys do it? And then all of a sudden, the nurses have been saying, why don't we do that? And surgeons sitting back and saying, we've been telling this for 4 years. But it's good. I mean, the important thing is people are willing to change. And we really want to get hold of that change to move forward, move from 6 to 8 to 9. And it is possible, but the whole team has to work towards that. It's very rare where all three different groups, you know, the nurses, the managers, the surgeons, all of them agree to one point. And this is one of those rare events. You just have to utilize that.
Yeah.
Brilliant. Well, I mean, it sounds like great work. It's very impressive. And I think that one of the things we did learn from the recent college clinical leads survey, which I was talking about earlier, is that I know what Sudesh was saying earlier about, you know, that there are people who are a bit sort of, we shouldn't do this, we can't do this. But I do think attitudes have changed a lot. So it's much more, it's not anymore about we shouldn't be doing 7, we shouldn't be doing 10. And we absolutely welcome that message you gave, Graham, that it's not all about banging us on the head to do 10, it's just about being more productive. Is that I think there's been quite a sea change, and there are now a lot of units and a lot of surgeons out there that are really keen to do this, but are struggling to. So, but that's great, you know, that the attitude has changed, and I think, you know, this level of detail and support is definitely the way to go. Bertie, I think should we give you the last word?
Well, you shouldn't forget the surgeons. I think we've always concentrating that the resistance is from the other groups. There is resistance from surgeons too, because a lot of us have not trained in high volume work. It's not as simple or as easy. How I have sold it to the surgeons is there'll be 2 of you. All other parts of the pathway will be streamlined. So we expect you to come, we expect you to operate, and we will take the responsibility for the rest of the pathway. And that's the kind of assurance I've given the surgeons here. I think that's how we've made sure the surgeons have agreed to do it. They have not done it yet, but they've agreed to do it. So that's the responsibility I am taking. I have to make sure, or as a team, we need to make sure that the rest of the pathway is slick, so the surgeon is there to operate and get the work done.
Yeah, that sounds about right to me. So I just wanted to say a big thank you to all speakers. Thank you very much to Elena, Graham, Bertie and Josh. That was really interesting, and we look forward to hopefully hearing more updates back from you, Bertie, in due course. So thanks everyone for attending. As I said, the recording will go on the UKOA website soon, and do get in touch about any of this, about if you're interested in hearing more about any of this. We can definitely direct you to the right people, both within GIRFT or the eye care programme, or anyone else, for people who'd like to know a bit more about any of the details we've discussed today, and hopefully look forward to seeing you at next month's event. All right, thanks very much. Have a good rest of the day. Bye.